Good afternoon and welcome to our oncology lecture series. My name is Dr. Rogelio E. Ribas. I'm the Corporate Vice President of Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located at the bottom of your screen. I will also be the moderator today, fielding any questions you might have. This afternoon, I have the pleasure of introducing Dr. Rohan Garje. His presentation is titled Advances in the Field of Prostate Cancer. Dr. Garje is a medical oncologist and chief of genitourinary medical oncology at the Baptist Health Miami Cancer Institute. He is board certified in internal medicine and medical oncology. Dr. Garje specializes in the treatment of prostate, kidney, bladder, testicular, and penile cancer. Dr. Garje received his medical degree at Osmania Medical College in India. He attended Fairview Hospital, Cleveland Clinic in Ohio for an internship in internal medicine and residency, followed by a hematology oncology fellowship at the Roy J. and Lucille A. Carver College of Medicine at the University of Iowa. Before joining Baptist Health Miami Cancer Institute in 2022, Dr. Garje served as an associate professor of medicine in hematology and oncology at the University of Iowa in the Holden Comprehensive Cancer Center. He is an expert in the design of novel investigator-initiated clinical trials and participated in the VISION clinical trial that led to the first radioligand 177LU PSMA for the treatment of prostate cancer. At the Institute, he leads a team of medical oncologists actively involved in clinical research, bringing industry-leading treatments to patients with genitourinary cancers. Dr. Garje is an internationally published leader in cancer research. He has amassed over 30 publications in prestigious journals, such as the Journal of Clinical Oncology and the Journal of Immunotherapy for Cancer. Dr. Garje is the chair of the Castration-Resistant Prostate Cancer Guidelines Committee for the American Society of Clinical Oncology. He leads the committee's work in reviewing research and writing guidelines for prostate cancer treatment. Dr. Garje serves on the editorial board for Current Problems in Cancer and is a reviewer for multiple journals, including the Journal of Clinical Oncology and the Journal of Oncology Practice. Please, let's give a warm welcome to Dr. Rohan Garje. Dr. Garje, thank you.
All right. Thank you so much for such a warm welcome, Dr. Ribas. I'm excited to talk to the group and, as you said, I'm a medical oncologist with a focus on prostate cancer, kidney, bladder, and testicular cancers. We have a very robust practice here at Miami Cancer Institute, and we offer patients not only standard of care treatments, but also novel new clinical trials. So with that, my talk is focused on prostate cancer. I would like to discuss, various aspects that have recently changed the way how we treat prostate cancer. So let me start with my screen here. All right, I hope you're all able to see my screen. So this is my talk. So I have shared my email ID and phone number, and I'll display it at the end as well. So I receive an institutional grant for research from J&J Pharmaceuticals. This is my conflict of interest. The objectives of my talk are about, to discuss primarily about prostate cancer, look at the epidemiology and screening, look at the new treatment updates, what are the different types of treatments we have for prostate cancer, primarily for advanced prostate cancer, what are the new biomarkers that are available for the treatment of prostate cancer, new drugs such as PARP inhibitors in prostate cancer, or what are the new imaging technologies that have come up in prostate cancer diagnostics as well as treatments. And then I'll talk about the radioligand therapeutics that have recently come up as new treatment choice for prostate cancer. Let's dive into epidemiology. Yeah. Prostate cancer is one of the most common cancers in men. You know, if we look at the statistics in United States, every year, American Cancer Society and SEER, they release the expected number of cases. And if you look here, the prostate cancer is the second most common cancer in general. Last year in 2022, about 268,000 new cases were estimated, with associated deaths of about 35,000. And it constitutes about 14% of all new cancer cases. When you look at it globally, at a global level, this data is maintained by WHO, where they report incidences across various continents, various countries. And then if you see here, the incidence per 100,000 population, highest is in North America and Europe. And I'll get there quickly. And then the instance after that is seen in more in oceanic countries, and then Latin America has a reasonable incidence, about 59 cases per 100,000 population, and lesser number of cases in Asia and Africa. In terms of mortality as well, based on the places where the incidence is high, we do see mortality in higher proportions in those areas. Now, the next is, prostate cancer, it has some predilection to race and ethnicity. The highest incidence in general is in African American. And then it is followed by non-Hispanics, then Caucasians, and Hispanic population after that. And similarly, the mortality from prostate cancer is highest in African American origin or Black population. And then the other races are reasonably lower, and the least mortality is noted in Asian or Pacific Islander population. The next,
Doctor, is there a way we can change the presentation, because they're seeing the next slide and it's not like propagating for them completely?
Okay. All right. Thanks.
There you go. Almost. Slideshow.
Give me one. Okay. I hope you're seeing the full screen now.
There you go. Yep. Thank you, sir. Sorry to bother you.
Yeah. So I'm glad that these are the most important slides as well. So, okay. So whenever prostate is diagnosed based on prostate biopsy, prostate cancer, and most patients fortunately are diagnosed with a localized disease where the cancer is restricted to prostate. And then we differentiate them into low risk, intermediate risk, and high risk. And if they spread to, sometimes it can spread to the lymph nodes, which is seen in about 12% of patients. And then it is widespread where it has spread to the bones predominantly, or sometimes to other organs such as lung and liver. Fairly, that is in a lower percentage, about 5% of the patients. And then again, in terms of risk factors, who are at risk for prostate cancer? So prostate cancer is common in aging population. So the median age of diagnosis is 67. And as I was previously discussing, the incidence is highest in African Americans. And then there are additional genomic predispositions. Patients who have first-degree family members with a history of prostate cancer at high risk in general. And then folks who have familial gene mutations such as BRCA1, BRCA2, CHEK2, ATM, those are all associated with prostate cancer. And Lynch syndrome is also well known to have a higher predilection to development of prostate cancer in addition to colon cancer. Moving forward, I think the most important aspect is screening. The way we will get to know about prostate cancer is only through screening, because most patients are in general asymptomatic. Now, what are the benefits of prostate cancer screening? And it is generally done by checking for PSA values, digital rectal exam, and then subsequent biopsies. Now, the benefit of early screening is we identify high-risk prostate cancer, which is hopefully restricted to prostate, and so we can do a definitive treatment and cure the patients from cancer. So that's the benefit. And then also by screening the patients to identify the cancer at an early stage, the goal would be to prevent morbidity and mortality associated with advanced prostate cancer. Now, and the studies have shown that, when patients undergo screening, or when men undergo screening for prostate cancer between the age group of 55 to 70, by screening about 1,000 men, we can prevent about 2 deaths over 13 years. So it's kind of a big number needed to treat. So this created a lot of difference in opinion who needs to be treated, how much is the benefit and how much is the harm with the treatment. So what are the potential harms? Okay, we can screen the patients for prostate cancer by checking PSA and then diagnose them with cancer. But the problem is we are overdiagnosing them, because there are a lot of prostate cancers which are not life-threatening, which are localized, which are indolent. And by diagnosing them, we are creating unnecessary anxiety and stress for the patient that they have cancer, and then they have to undergo some sort of treatment, which otherwise, if undetected, would not have been fatal. And then over-treatment, as I just said, so patients who get diagnosis of prostate cancer, no matter what, if it is a low-risk cancer, they go for treatments and have subsequent complications. And then complications from the over-treatment. Now, it is an interesting study I would like to quote. There has been done a study, autopsy studies done in patients who passed away from reasons other than prostate cancer. And then the incidence of incidental prostate cancer in that group was looked at. And it was surprising to see that men who died from other reasons who were younger than 30 years had 5% chance of having prostate cancer. And then men who are greater than 79 years old, they passed away from various reasons when they had 50% chance of having a prostate cancer. So this indirectly tells us that a lot of people live with prostate cancer without manifesting the symptoms and may die from other reasons. So there are a lot of patients with indolent cancer which will be who will be detected with screening. And then once they get diagnosed with cancer, they get treatment for it, which eventually leads to some complications. So sexual impotence, urinary incontinence, and bothersome bowel symptoms. So based on this, scenario, in US specifically, there is a task force, US Prevention Task Force, which came up with guidelines saying that screening should be done between 55 to 70, and then they have to discuss various aspects of screening. Now, based on that change, actually, the incidence of prostate cancer came down in US. But added to that, now that the problem which we eventually now face is because we have cut down on the screening, now the number of people with advanced prostate cancer has gone up. Now, there's an alarming increase. Actually, earlier this year in January, American Cancer Society has released a statement when they looked at the last 10 years of the incidence of prostate cancer at various stages. The number of men with advanced stage prostate cancer has increased 5% per year in the last 10 years, which is obviously a problem. So obviously we have to strike a balance. So now by underscreening, what we are ending up doing is letting the patients develop advanced disease, which eventually is not curable. So the cancer which was potentially curable has turned into a non-curable cancer. So where is the balance? How do we overcome the features of overdiagnosis versus undertreatment, and then letting the patients progress? So based on all these discussions, I think it's very important. So there is no one right answer in the situation, but it's very important for the primary care physicians in the whole group now, in the webinar, to be very cognizant about this issue and make every effort to talk to their patients, who come for routine physical or have a family history, especially when they turn at age 50, to discuss pros and cons of prostate cancer screening. Look at their risk, see if they have a family history of prostate cancer, look at if they are African American in origin, they are at high risk. People who have a relative, a father or a brother who was diagnosed with early age prostate cancer, or who have family history of cancers, should definitely be discussed. You have to discuss the risk and benefits of screening and make an informed decision. What are the benefits of screening, that you will be, if there is a risk of cancer, we'll identify it early. It will be a low risk, hopefully, or intermediate or high risk based on how it is. And then there are treatment choices. But also be cognizant that there may be potential side effects. Discuss the risk and benefits of the side effects of treatment, and then make an informed decision. I think this is very critical. And also the key is not to let go of the high-risk patients. People who have family history, people with African-American history, because as I previously showed, the mortality is highest in African-American group. It's very critical to screen them for prostate cancer. So moving forward, beyond screening, now what are the treatments? What do we have? How do we treat the patients? Now, I would like to start with the history of treatment, because it is very interesting to see how the treatment has evolved over the last century. Now, if the cancer is restricted to prostate, one could do either surgery or radiation therapy. Both are equally effective. And the first ever surgery in the form of radical perineal prostatectomy was done in 1904. Now we have advanced the surgical approaches. At MCI, at Miami Cancer Institute, we do offer radical prostatectomies, but mostly robotic, which is quick, fast, and with minimal side effects. The biggest thing is we do offer nerve-sparing prostatectomies, so the risk of erectile dysfunction or sexual dysfunction is much lower. And then the other most important component of our prostate cancer treatment is hormone therapy, where we cut down the testosterone production in the body. And this has been noted in 1941 by Dr. Charles Higgins, who is practiced at Chicago. And this treatment has been so revolutionary that we are still using it now. So we are almost 80 years past his discovery. And this still is the backbone of the treatment of prostate cancer. And based on his novel discovery in 1966, he did receive a Nobel Prize in physiology for his discovery. And in 1966, we started using Gleason grade, which is a grading system for prostate cancer, where we grade the prostate cancer over the range of Gleason grade 6 to 10. And then in 1985, Leuprolide, one of the hormone injections, was discovered. In 1986, we started using PSA, prostate-specific antigen, to monitor for metastatic prostate cancer diagnosis and treatment response. And subsequently, we are using it for prostate cancer screening as a common screening tool. And in 2004, we have docetaxel, a chemotherapy drug that got approved. In 2010, we have two drugs that got approved, cabazitaxel and Sipuleucel T, which is an immunotherapy drug. In 2012, we have abiraterone and enzalutamide, which are hormone agents. In 2014, we have radium-223 approved. And in the last 2-3 years, we have PARP inhibitors, olaparib and rucaparib, that got approved in the treatment of prostate cancer. And then most recently, in the last couple of years, we have now this new agent called PSMA lutetium-177. Now, as an oncologist, when I see patients with prostate cancer, it's not one diagnosis fits all scenario. Each patient has a different situation, different clinical setup. So we have to first understand where they are in the cancer history. Is it someone who is newly diagnosed and the cancer is restricted to prostate, or locally advanced where it is protruding out of prostate into surrounding structures, or gone to the lymph nodes? That is one group. Or if they had surgery or radiation, and despite that, their PSA starts to go up, then we use the word biochemical relapse, where there is no evidence of cancer on the scan, but the PSA is going up. Or there are patients where they're diagnosed with metastatic cancer at the outright, where the cancer is present beyond the prostate, in the lymph nodes, in the bones, etc. And then there are two different scenarios. When they're newly diagnosed, they're generally sensitive to hormone therapy. So we use the word castration-sensitive prostate cancer. But once they become resistant to the treatment, to hormone deprivation, then we use the word castration-resistant prostate cancer. And then there is a small fraction of prostate cancer patients where with treatment, the cancer evolves and turns into something called small cell or neuroendocrine transformation. So the big goal for us as cancer experts who focus only on prostate is to try to understand where they are in the system in terms of the diagnosis and staging, and what treatment is appropriate for their stage, and what clinical trials would be appropriate for this stage. So taking a little deeper dive. So anyone with prostate cancer, we have curative intent treatment. We divide them into low risk, intermediate risk, or high risk based on what is the Gleason score, what is the TNM stage, and what is the PSA value. And for people with low risk, if they have less than 10-year life expectancy, we can just watch them, because the risk of them dying from prostate cancer is so low, we could actually watch them. So that is very important. So low risk is someone with a very indolent disease, low PSA, Gleason score 6, cancer restricted within the prostate. And if they have a life expectancy of less than 10, there are various calculators we have based on various demographics, based on, in general, each country has their own life expectancy parameters. And then the eyeball test, looking at the patient in general, it would be futile to check a 80-year-old with heart failure, respiratory failure for prostate cancer, because they have multiple other comorbidities. So kind of gauging the patient by patient. Whereas if it is intermediate risk, we can do radiation or surgery. And if they have high risk, we can do radiation, we can do surgery, and also use some hormone therapy with something called abiraterone, which has shown to improve survival for these patients. Now, androgen deprivation therapy, as I just mentioned, it's the backbone of the treatment of prostate cancer. Anyone with locally advanced or metastatic prostate cancer, the standard starting treatment is androgen deprivation therapy. The reason being, testosterone is actually the stimulus for the cancer to grow and spread. So this is the best way we can suppress the testosterone. And there are various ways, if you are, look at the hypothalamo-pituitary and testicular axis, hypothalamus secretes pulsatile GnRH hormones, which act on anterior pituitary, which stimulate FSH and luteinizing hormone, which act on the testis and release testosterone. And this testosterone is helping the prostate cancer to grow and spread. I tell my patients, testosterone is not the cause for the cancer. It's not because of the testosterone levels in the body that the testosterone has converted normal prostate to cancer. But once a cancer develops in the prostate, this unfortunately helps the cancer to grow and spread. So we have various agents that control the production of their hormones. I want to bring your attention, the hormone therapy has been traditionally the injections. But recently, there is a new drug by name relugolix. It's an oral pill, which has been approved for the treatment of prostate cancer. And there was a big study called HERO, which was which compared the efficacy of relugolix pill, which is a GnRH antagonist, to leuprolide, which is GnRH agonist. Now, as the big benefits of this pill in general are, it is quick to act. As soon as the patient start taking the medication, its efficacy is seen. The testosterone levels go down quickly within 4 days. The goal is to bring the testosterone levels to less than 50. So by day 4, the numbers are less than 50. Whereas with Lupron, it remained elevated to 625. Now, the other most important thing is if the patients develop undue side effects, where the hormone therapy has caused them profound testosterone deprivation related side effects, testosterone reversal takes time with Lupron, because these are injections which are given every 3 months, every 4 months, every 6 months. Once the injection is given, it cannot be undone unless you give them testosterone supplements. Whereas with the pill relugolix, as soon as you stop it, within 90 days, the numbers come back to normal range. So it is very important to discuss this as an option. It is a new drug which has been just approved in the last 1 to 1.5 years. So in specific patients, young patients who are very concerned about side effects, it's very critical for them to present this option and see if that option is beneficial for the patients. Moving forward, at a completely different note, when we talk about hormone deprivation, testosterone is mainly produced by testicles. So one could say, why not do surgical castration, where instead of giving this hormone injections, this expensive pills, which is very expensive, in a big picture, each country may have different pricing, but eventually these are expensive medications. Why not just offer surgery where both the testicles are removed? For whatever unfortunate reason, in United States, at least, the utilization of surgical castration is very minimal. The numbers here are actually the reverse. I did actually a study where we looked up all the hospital database across the United States. We looked at about 3 to 4 million patient data actually. And then what we saw was surprising, where medical castration was predominantly used in 94%, and surgical castration, where surgery was done to remove the testicles, was used only in about 6%. Now, this has cost implications, lifetime expenditure on medical castration is very high compared to surgical castration. Now, it's a busy slide. It has so much of information. So what we have seen is hormone injections, androgen deprivation therapy alone is good, but not best. Within 18 months of start of therapy, for patients who have advanced cancer, the cancer starts to progress. So what can we do at an upfront setting where we can do more treatment to improve the outcomes? So based on this, there were several studies that were done. I will name them: Charted, Stampede, Latitude, Enzymed, Arches, and Titan. They looked at not only hormone therapy, but they looked at if we added chemotherapy with docetaxel or novel additional hormone therapy agents by name abiraterone or enzalutamide or apalutamide. The addition of these additional agents is called doublet therapy, has significantly improved survival. So now this is the main standard of care. Using hormone therapy alone with ADT is very rare and exceptional in specific patient situations. But in general, this doublet therapy is what we recommend right now. This has improved the survival by more than a year or two compared to hormone therapy alone. Now then, what is a new thing? In the last year, we have two big studies that coming up with something called triplet therapy. So not only hormone injections in the form of ADT, but by using chemotherapy and the hormone pills called darolutamide or abiraterone were tested in these two big studies, ARASENS and PEACE-1. And this triplet combination has shown to improve survival compared to this doublet of hormone injections and chemotherapy. Now, there is some criticism for these two studies. As you can see, the survival curves are separated. People and the hazard ratios are also favoring improving survival with the triplet therapy. Now, will all patients benefit? How much is the benefit? How much is at the cost of a lot of side effects? So that has been debated. So the bottom line, when we look at patients who have advanced prostate cancer, where the cancer has spread to lymph nodes and bones and everywhere, now, not everyone would benefit with this triplet therapy. We specifically identify patients who have higher disease burden or newly diagnosed with widespread metastatic disease. We use the word de novo metastatic disease or high volume based on a specific criteria called Charted criteria, where they have visceral metastatic disease. And in those patients, we offer triplet therapy. So, but the thing you can see is patients are, we didn't even reach the median. We have a 5-year follow-up, and the patients are more than 65% of patients are alive after 5 years. So with this, what I'm trying to convey is, now a stage 4 metastatic cancer patients, more than 60 to 70% patients are living beyond 5 years, which is, phenomenal compared to what we knew about this cancer several years ago. So moving on, for the primary care team members in the group, I wanted to present this slide. Hormone therapy is not simple therapy. When you deprive the patient's body of testosterone, you're helping them with the cancer control, but they get a lot of side effects. They get hot flashes, they develop decreased libido as a problem, they develop osteopenia, osteoporosis, and risk of fractures, and then they may develop cardiovascular problems. So our goal here is to give them multidisciplinary care. We want them to live longer, but also have a better quality of life. So not only, control the cancer, to overcome those side effects which are common with this, we tend to give good support for them by using, for example, hot flashes, which is the #1 side effect with this treatment almost every man who gets this treatment gets it. So we do have various treatment modalities to control them. So this is important to educate the patients that even if you develop side effects, we have several measures by which we can help you with the side effects. And I always tell my patients that to take vitamin D and calcium supplements, because osteopenia and osteoporosis are very common problems with hormone therapy on long-term use. Now, what are the new things? What are the biomarkers? In this new day and age, prostate cancer is histological diagnosis, but we want to know what is the genetic makeup of the cancer? What is driving the cancer? So what we have learned is in the last 5 to 10 years, the TP53, P10, androgen receptor, MYC, BRCA1, RB1, these are the common mutations which run in the cancer. For example, BRCA2, which is seen in almost 10 to 12% of advanced prostate cancer patients. It is critical to know about these mutations because now we have drugs which can target these mutations and help control the cancer. So what we generally tend to do is anyone with advanced prostate cancer, we obtain genomic testing. We run the genetic code of the cancer to understand what is driving the cancer. And in the end, I'll show one slide where in future, these critical pieces of information from genetic makeup of the cancer will change the way how we treat the cancer. Now, I'll get into additional details in the end, but this is something which I wanted to share. So I was sharing that the BRCA, BRCA1 mutation, and there are so many other mutations which are clubbed together as homologous recombinant repair, HRR pathway mutations. And if patients have those mutations and they have advanced progressive cancer despite the prior doublet or triplet therapy, now we use medications by name olaparib and rucaparib, and which have shown to help control the cancer. And then there is another scenario called microsatellite instability, which is seen in Lynch syndrome as a germline problem, or sometimes it's acquired due to changes in their mutations. And if patients have this scenario where there is MSI high or deficiency in repairing their abnormal genes, then we can use pembrolizumab, which is a checkpoint inhibitor, and it has shown to improve the survival. And if the cancers have higher mutation burden as well, we have the option of using pembrolizumab to treat the cancer. Now, I'll skip this. Now, what is the other thing? What are the additional new agents now? So we have novel imaging and novel therapeutics which have recently come up. Now, I want to bring to your attention a concept called PSMA antigen. Now, prostate cancer has this unique receptor called prostate-specific membrane antigen. Now, it is expressed, widely, in prostate cancer, and based on different staging, in patients who have metastatic castration-resistant prostate cancer, the expression is very high, almost in 90% of the patients. It is also expressed in normal tissues, for example, the salivary glands, the breast tissue, the pancreas. The important thing is we can attach radio tracers to these receptors and use for imaging, so for diagnostic purposes. And also we can use these receptors to target agents which are used to treat the cancer, so therapeutic purposes. So this novel receptor for which we have diagnostic imaging as well as therapeutic intervention, this whole concept is called theranostics, which is a rapidly developing concept in the field of prostate cancer. A similar concept is in neuroendocrine tumors in GI origin, where there's a drug called Lutathera that has been used for the last 10 years. Now, as I was saying, so traditionally, when we stage or evaluate for cancer, we use a CT scan and bone scan for prostate cancer. But the problem with prostate cancer is its sensitivity is poor. Sometimes they are not able to delineate the exact extent of cancer. And so to improve upon that, as I was just previously sharing, PSMA has been used as a novel target to image. And so based on this, we have two new agents, gallium-68 PSMA11 and pylori-5 F18, which is a novel imaging technology, which we use now for both, for patients with high-risk prostate cancer, for patients who had surgery or radiation and had rising PSA, so biochemical relapse prostate cancer, and also for patients who are with metastatic prostate cancer and went through a few lines of therapy to image them and also to come up with treatment options. And there is another scan called Axumin scan, which has been used for a few years, but with the advent of PSMA scan, this particular scan called Axumin scan has gone down in the utility. Now, just to give you one example, of a patient scenario, a patient with newly diagnosed prostate cancer, the cancer is restricted to prostate, conventional CT scan and bone scan was done. And in that scan, there was no evidence of metastatic disease. The PSA was 13 and the Gleason score was 9. And whenever we have a PSA more than 10, we are concerned of metastatic disease. This patient underwent traditional bone scan, nothing significant was noted, but when they went for the PSMA scan, it showed this high level of widespread metastatic disease. So we have changed the diagnosis, we have improved upon the staging of the cancer, and now the treatment has completely changed for the better outcomes of the patient. So it's very critical to be cognizant of this imaging modality. Actually at Miami Cancer Institute here, we do this scans very periodically, and this has revolutionized the treatment of the patients and to get them the better treatment choices. Now, as I was saying, so in addition to the PSMA being a imaging target, it can also be used for delivering therapy. So this is a very busy picture, but I want to bring attention to these 4 novel therapies which are upcoming. One is radioligand therapies, which I'll touch again in the next few slides, where the prostate cancer cell, which is expressing the PSMA, we deliver lutetium-177, which is a beta radiation, which is given via IV. It goes all over the body, but attaches only to the cancer cells and delivers targeted radiation therapy to the cancer cells and causes targeted DNA damage with less collateral damage. Normal tissues are not exposed. So this is a very novel therapy. There are various agents. So current drug which we have is lutetium-177, but there are actinium, thorium, yttrium, iodine, which are rapidly developing. So in the next 5 to 10 years, I think these drugs will be available and will revolutionize the treatment of the prostate cancer patients. And then there's another concept called antibody drug conjugates. So the same concept, finding a mechanism to attach to the PSMA, but to deliver chemotherapy within the cancer cells. The exact analogy would be for breast cancer. There's a drug called trastuzumab, where the chemo drug was delivered directly to HER2 expressing cancer cells. Now, in the day and age of CAR T therapy, engineered T cells, if you would, followed the world of hematological malignancies, there are 5 CAR T therapy drugs for leukemia, lymphoma, and multiple myeloma. So these drugs are being developed for prostate cancer as well. It's still in the early stages, phase 1 studies, but excited about it because people are seeing phenomenal responses, but this will be practice changing potentially in 10 years, but not in the next 5 years. And then there is another concept called bispecific T cell engaging antibodies, which are also being developed. So very exciting target. So what do we have as of today? So there is this clinical trial called Vision, which I participated in, and where we looked at the evaluation of lutetium-177 on the top of standard of care for patients with advanced prostate cancer who went through more than a couple lines of therapy. And what we saw was people who got this investigational agent called lutetium, the survival was significantly better compared to those who did not get it. Now the survival and was about 15 months compared to 11 months. And this is a group of patients who were treated with several lines of treatment before. If this treatment was not available, the life expectancy would have been much shorter. So it is very important. And based on this, actually, I was fortunate enough to work with ASCO because one of my role beyond, being a clinician and researcher is I also work for, I volunteer, not work, I volunteer for ASCO, where I write prostate cancer treatment guidelines. So last year we updated how to treat prostate cancer, castration-resistant prostate cancer, and we came up with these guidelines, how to give this drug, what is the frequency, how to select patients based on imaging, how to call a particular scan positive, and how to monitor them based on blood work, kidney function, what are the radiation protection mechanisms to be recommended for the patient. So it is a novel and exciting opportunity for patients, and I'm hopeful that the patients will benefit from this. So what next? How do we improve upon this lutetium? So what we are doing here at Miami Cancer Institute is come up with novel clinical trials where, lutetium, as you saw, it is improving the survival, but there is still room for improvement. How do we make it work better? So we actually are opening a study. It's an investigator-initiated study, which I'm running. I'm the principal investigator on the study. It is one of the first such studies in the United States, where we are combining lutetium with this drug called niraparib and abiraterone to see if we can improve the outcomes. So it's a triplet therapy, fairly, we have to be cognizant about tolerability, but the idea behind, the hypothesis behind this is, just to give a little bit basic science of it, lutetium, the way it works is it's a radiation therapy. So radiation works by damaging the DNA, but the resistance to that is the cell will figure out, the cancer cell will figure out a mechanism to repair the DNA. Now, niraparib and abiraterone, when given together at a low dose, inhibit the repair process of the DNA. So the concept is to induce DNA damage by using these radioligand therapies and then prevent it from repairing, and hence improve the response and keep it durable for a longer duration. So we are very excited about this study. We are the only institution in US to have this combination study, and it is a funded study, and we are planning to enroll patients in the fall. So roughly about, I'm assuming in the next 6 to 10 months, we'll have it up and running. So this will be a study for patients with advanced prostate cancer who went through a couple of lines of therapy and not seeing any benefit and want to explore new novel therapies. I think it will be an exciting option. We also have another study here for anyone who has newly diagnosed prostate cancer, who is advanced, to see if lutetium can help and improve their outcomes. Because we know it helps in late stages, why not in upfront setting? So we are excited about what we have to offer for prostate cancer patients, and definitely we have seen a lot of referrals for patients outside of country, primarily for standard of care when they're as well, but also, if things work out for them to participate in clinical trials, these studies will be a great opportunity for them. So I look forward to see referrals, and the best thing is, once we have a clinical trial eligibility selected for our patients, it runs very quickly and helps the patients really well. Now, I want to end my talk talking about future. I spoke about the genomic markers. I spoke about disease stratification based on high volume, low volume, de novo or metastatic, and then based on positivity and PSMA scan. So currently we use hormone therapy, the doublet or triplet for treatment of prostate cancer. But I'm hoping in the next 10 years, based on all the new trials that are ongoing, the treatment will be very precise based on particular patient scenario, based on what mutations they have, based on the PSMA scan positivity. So it's not just one treatment for all the patients, but it is a specific treatment for a particular patient based on what the genetic makeup is and what the scans show. So I'm very excited with the way the field is evolving. So things have changed drastically. And then I would like to conclude saying that, for the primary care folks in the webinar, please make an attempt to discuss pros and cons of prostate cancer screening with all men who you see for routine follow-up, for routine health. We have traditionally used hormone therapy and chemotherapy, but now we have this novel imaging-based tools to better define the cancer and use PSA-directed radioligands and T-cell therapies. And specialized patients will benefit with PARP therapy as well as checkpoint inhibitor therapy. So with this, I would like to conclude my talk and would be eager to hear from the audience to see what questions they have and how I could work with you, to help care for your patients, provide opinions in future. I just want to leave the screen so that you can see my phone number, my email ID, so you can feel free to contact me with any questions. If you have your own patient, want to know some advice, I would be keen and happy to help you with that. All right. Thank you so much for your time.
Thank you, doctor. What an amazing presentation. So many questions, don't even know where to start, but you hit the number one question at the end. There's so many cultural differences, right? We all, as men, whether it's African-American, whether it's Latin, there's these cultural norms that people are afraid of certain things. Mm-hmm. And you mentioned there's a lot of GPs on this talk. And so how do you recommend to broach it? How do you recommend to touch the subject and move forward?
Yeah, I know it's, I'm also, my upbringing has been from a country where the cultural aspects were people don't want the C word to be heard. That is the biggest, drawback, especially, in US, fortunately, that barrier has been overcome where talking about prostate cancer screening, breast cancer screening, cervical cancer screening, or colon cancer screening is fortunately a little bit easy. But to break the norms, I think it's very critical to talk, I think it has to be brought up by the primary care physicians. I'm sure the patients or men who follow with the physicians there would have some sort of routine conversations. So based on the vulnerabilities, based on the things, maybe asking about family history, who else has cancer, to kind of generate the conversation and asking the family history, any high risk cancers in the family would help them open up about the conversation. And in general, and also to talk about, in general screening, what are the pros and cons and what are the benefits, if a cancer can be cured when it is identified early, by using surgery or radiation and then preventing, morbidity from it, I think it's very critical. So I think it has to be overcome. It takes time. There is no easy way. But unless it's spoken about, there is no way we can get into screening. So I think it is a much national level conversation, more like initiative from the governments or, at a healthcare level, so that this conversation has been brought at various avenues and it becomes easy for screening.
Thank you, doctor. And going along with that, there's a question from Freeport, Bahamas. Percentage like correlation between prostate enlargements and cases becoming cancer, or percentages of prostate enlargement cases that do not become cancer. Can you help us with that?
Sure. So BPH, benign prostatic hypertrophy, is one of the most common problems. The risk of BPH turning into cancer is minimal. It's not a precursor for cancer for a lot of patients. So having said that, so that is not a concern of most of our patients. Most of them are in general, the prostate cancer, it's still, it arises from the central part of the prostate where it tends to cause symptoms for sure. It is known to cause urinary flow problems, frequency, narrow stream, dribbling. But the risk of BPH, benign prostatic hypertrophy, to convert to cancer is fortunately very rare. The risk is, as I previously mentioned, the top 3 risk factors are aging, just being old and letting the normal cancer cells turn into normal prostate cells turn into cancer. So that is the main thing. And genetic is the other reason.
Thank you, doctor. At an age where you see so many publicized testosterone treatments for men for performance, all types of issues, what do you see in the fact of oncology? Do you see any increase of cancer due to testosterone treatments? What can you share with us?
Sure. Good question. So far, the biggest educational point I tell my patients is, if they were on testosterone supplements as well, there's no direct correlation that when men without any prostate cancer, if they have been having symptoms of hypogonadism or low testosterone, and if they receive testosterone supplements for low hormones, the risk of them developing prostate cancer because they took the supplements is very low or minimal. It is not the number one risk concern. So obviously there are indications, for testosterone supplements. It's not just feeling low fatigue. It has to be the conundrum of hypogonadism, that low testosterone leading to muscle fatigue, testicular atrophy, and all those aspects. Then it would be really of benefit to offer testosterone supplements.
Any correlation, prostatic cancer is a question from Costa Rica, correlation between prostatic cancer and if a patient previously had some form of kidney cancer, anything to worry about there?
Fortunately, no. So both fortunately are separate etiologies. So if the question is, if someone had a history of kidney cancer, so testosterone use should not affect any of, I don't think there's any correlation.
So we're all excited that we have folks like you at the Miami Cancer Institute. We went from a time where everything was done on a generalist situation, or when each surgeon did their thing. Can you talk a little bit about how having your tumor boards, how you all collaborate, how does that help our patients?
Excellent question. It's a multidisciplinary approach. You rightly said, there has been an era where these most of the prostate cancer patients were either treated primarily by the urology team or sometimes by radiation oncology. But now we make every effort to discuss all the patients at a tumor board level, where any imaging abnormality, any pathology abnormality, or any the clinical situation doesn't match with what's going on with the patient's care, we discuss in the tumor board. We meet weekly, where folks from my group, medical oncology, radiation oncology, urology, pathology, radiology, so it's and the nurse practice. So it's a big group. Everyone chimes in. We discuss the case, and actually the evidence actually has clearly shown that cases or patient scenarios which are discussed in tumor board have in general best outcomes because it has received multiple inputs. So I always encourage these discussions, and it is going to definitely improve the patient outcomes.
So doctor, we have, the PSMA now available. Axiom was a big deal, and now it's not so much a big deal. So let's say a patient is in our countries. We deal a lot with international, with different hospital systems and everything else. And maybe that technology might not be available. How could we help?
So, fortunately, PSMA scans are, here they are readily available, and there are international patients who are still able to come here, get those scans. There is a mechanism, fortunately, it's getting affordable as well now. There are some places where it can be done much lower price. So I think, it has a major, impact in improving the treatment strategy and overall outcome. So in high-risk localized prostate cancer patients and metastatic prostate cancer patients, we tend to get the scans, and I think it's very critical. So MCI here, we are fortunate to have this option available, and we can do the scan fairly within a week, and the interpretation is very quick, and we have experienced radiologists. I personally have a lot of experience. I have seen thousands of these scans so far in my career. So I feel fortunate that I can accurately stage based on those scans. So if there is an international patient who is interested, and I think we can make it happen for them, obviously we'll work with the international team, like, with your group, get them here safely and get these kind of new scans, give them a treatment strategy, and they can go back. And what I have been doing, I've been fairly new to the group, but what I've clearly done in the last 8 months, fortunate that I have seen a lot of international patients already. I make every effort to communicate with the referring primary care, urology, or medical oncology folks who have referred their patient, come up with the treatment strategy, discuss the treatment plan, give them a detailed note, and actually call them. That is the easiest thing, call them and discuss that, okay, this is the scenario, we did this test, this is what we think is best. And I think, this could be safely done if possible back home. Let's get it done. Or if there is something that could be done here, which is not available back home, how do we make it happen? I have had some patients who have been receiving treatment here and they go back and continue assessments there. So they're getting the best of the both worlds, so that at the end of the day, if we can be available and provide exceptional service to improve the outcomes of the cancer patients, I mean, that is most rewarding. And this international collaboration, I think, is key. And the other big thing, which I have also been doing, is virtual support. I had a patient recently who got admitted due to some complications back in a different country. I called them every day. I spoke with the intensivist, medical oncologist on day-to-day basis, made sure the treatment is going okay. So, and that led to improved outcomes. And the patient and the family were extremely thankful because they didn't feel like, okay, we went back to a country and we're getting some cancer treatment in US. So it didn't make their life complicated. I was available for them to receive care even when they were back home.
It's one of the things that most proud of is we work for an organization that really cares about putting the patient first. There's a lot of organizations that will not share any of their protocols. We've been part of many cases that the patient started therapy here, and then after several sessions, then we were able, okay, this is working. How can we get it done back home? And those are the little things that count. Imagine patient being able to be home with their family, with their doctor and everybody around. And I applaud you all for this lunar study that's coming abroad. Coming towards us. These are things that we used to hear that you had to go somewhere else, and now it's available in Miami. And just a quick question, doctor, how many patients will be accepted into the lunar study approximately?
About 35 patients.
35. And obviously you have to qualify, but most international insurances won't cover a clinical trial, but yet the trial holders, the funders of the trial, will cover certain things, but the patients might be responsible for having to come out of pocket for certain diagnostic or lab situations. But they explain a little bit, Dr. Garje, why it's important that they have to stay here in Miami during the trial.
Yes, it's important. So various reasons. Obviously, there are a lot of trial-related measures. So when we have someone in a clinical trial, ideally, we prefer them to stay in the United States because it's a new drug, new combination. The FDA mandates us to make sure we follow them closely if there are any undue side effects that needs to be reported appropriately. So that's the main reason they have to be here. There are some standard of care which generally are standard irrespective of clinical trial. So sometimes insurance cover, be it again, with nuances of international insurance. But there is some funding provided by the study where we cover some costs of the study as well. Obviously, we have to tease out how much it costs for the patient and all those. But it is, this is an investigator-initiated trial. So I am the PI, I'm getting the funding. So will not be as heavily funded like an industry-sponsored study with a lot of millions of dollars. But with limited resources, I think it is extremely valuable. Actually, this kind of study is not available at MSKCC or Mayo or MD Anderson. So this will be available only at Miami Cancer Institute. So I'm very excited, though it is my study, but I'm very excited that it is such a novel combination, and I'm hopeful to help our patients with this.
Congratulations again on the study. And one last question from the Bahamas. If a young man wants to start prostate screening, how soon can they begin an annual PSA or prostate check? If they do not have a family history or experiencing symptoms, can they still complete these services?
Yes, very good question. I think the conversation should start at age 50. So there's a little bit varied rules of thoughts because we have 4 organizations which talk, but between 50 to 55 is the ideal time frame at age. And then stop at age 70. No need to start screening new patients after 70, unless there is a family history or symptom or something else.
Well, doctor, time flies when we're having fun, and this has been a lot of fun. I appreciate you, and I know a lot of folks can later on send more questions that we can get them over to you. and make the connection. So thank you very much. And with that, I would like to, on behalf of Baptist Health International, I'd like to thank Dr. Rohan Garje for his informative presentation and all of today's participants for your attendance. If you have any additional questions about today's presentations, please feel free to email them to us at BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We will get those questions over to the doctor to be able to help us and to be able to answer you and be able to assist in any way. We look forward to seeing you at our next oncology lecture series, which is scheduled for Wednesday, July 12th, 2023. Thank you again for all to be with us today. Have a great afternoon and a great evening. Thank you again, Doctor.
Thank you. Thank you so much for the invite.